Hello, everyone. Happy Black History Month and happy Heart Awareness Month. Thank you to our guests and listeners who are joining us today on this webinar. Thank you so much. You could be anywhere on a Thursday evening. So glad that you joined us today. I am Dr. Shawn Smith. I'm a pediatrician. I am what's called a hospitalist, which means I just work in the hospital and not in clinic or outpatient. And I work in the neonatal ICU. And I am at Northwestern University in Chicago, Illinois, and then also Lurie Children's Hospital in Chicago, Illinois. I also do some health equity teaching and implicit bias awareness for our medical students and our physicians trainees. And I also do a lot of community engagement and advocacy. And because I work in the NICU, I'm always down on labor and delivery. So I'm interested, of course, in maternal and infant health, specifically in the morbidity and mortality at both of those numbers. Um, and I am also a new member of the board of Birthing the Magic, and I'm so excited about this organization, which is about 2 years old, and I've been on the board now for less than 6 months. And very excited to be on this journey to learn more and to see where I can lend knowledge, bring in speakers. And with that, I would like to introduce my colleague and friend, Dr. Latasha Nelson. She is also at Northwestern University, and we've been there probably about the same amount of time, almost like 18 years. So we
We
have
were
seen
12
a
when we
lot.
got there.
We have seen a lot. Her bio is on the screen, but I'll just give briefly. She got her bachelor's at Alabama State University. I'm also an HBCU grad. She got her medical degree at University of Tennessee. She did her OB-GYN residency at Tulane University and her maternal fetal medicine or MFM fellowship at Northwestern University, where she stayed on. She also leads a health equity fellowship for, again, some of our physician trainees. And I've given a pediatric lecture there. We both lead health equity talks over at the medical school. So we have collaborated in a number of ways. We are also both boy moms. We both have two boys that are in that tween teen stage. Dr. Nelson just came from a parent teacher conference literally right before this.
Yes,
And I'm navigating the whole high school thing. So this is exciting and fun to be doing something a little bit different tonight.
absolutely.
So tonight we're going to be talking about hypertension and hypertension in pregnancy. And what we'll do is I'll let Dr. Nelson kind of take it away with a little intro. I do have some questions that have already been submitted by people like yourselves, either people who are pregnant, wanting to become pregnant, or just have a loved one and want to know more information to be able to be more knowledgeable, to answer questions for friends and family members. So we do want you to also ask questions, and you can put them in the chat or the Q&A. Actually, why don't you have you put the questions in the Q&A so in case there's a lot of chatter, I don't miss it. But do feel free to engage and interact in the chat, which I think is already active. So, Dr. Nelson, I am so glad that you are joining me tonight, and thank you so much.
Absolutely. Thank you for inviting me. I never turn on a chance to work with Dr. Smith. This is amazing. And this is actually a topic that's really near and dear to my heart. Understanding that I myself have hypertension. So when I got pregnant, this was something that was at the forefront of my mind for both of my pregnancies. Recognizing that as a person of color, my chances of doing poorly in pregnancy were higher than the general population. And one statistic that kind of stood out for me was that my likelihood of having morbidity or bad things happen during pregnancy as a person who has several graduate degrees was higher than a person of a white person with a high school diploma.
Mhm.
And so things like that make you think and you want to know why. And I think as we look into the why, one big thing is education so that we can all be advocates for ourselves. If the doctors aren't doing the things that we need, we can advocate and ask for those things that we need. And I think that's one thing that we can do as women to advance our health and to make everybody just a little bit safer.
Awesome. All righty, we are going to start. So people are introducing themselves in the chat. That's awesome. So we will start with the first question that was submitted. What are the different types of hypertension during pregnancy, and how do they differ?
Okay, so that's a really good question. Patients, when they come in, they're always, well, what type of hypertension do I have? So, first of all, the biggest bucket are going to be those women who come into pregnancy with chronic hypertension. That is a person who has high blood pressure, they were on medication, or sometimes they're not on medication because honestly, oftentimes we don't get care until we're pregnant, you know.
Yep.
But for those people who don't have care and don't have recognized hypertension prior to pregnancy, we look at those women in the first part of the pregnancy, the first 20 weeks. If we diagnose elevated blood pressure, we assume that those patients have chronic hypertension. And depending on how profound that chronic hypertension is, we may or may not choose to start medications during that part of pregnancy. The next type of hypertension that we get, we call gestational hypertension. So that's just pregnancy hypertension. It's diagnosed after in the second half of pregnancy, so 20 weeks and beyond. And those are the women who have new onset, high blood pressure, but none of the end organ symptoms that we think about, the lab work that we get. Um, um, then the next type would be preeclampsia. And that's the one that scares most of us because preeclampsia is
Mhm.
a special type of hypertension that only pregnant women can get. And we, as OBs, we really don't know exactly what causes it, but we know it has something to do with the placenta. And likely when that placenta implants in the very beginning of the pregnancy, that kind of sets the stage for preeclampsia that may come any point in time from 20 weeks to 40 weeks. The reason why we care about preeclampsia is pre-eclampsia. What is eclampsia? Eclampsia is seizures and strokes of pregnancy. And that's the part that when a woman develops preeclampsia, that's what we're trying to avoid. We're trying to get to a healthy point in pregnancy so we can deliver, so we can miss a lot of those morbidity, those bad things that can happen. One way that we delineate between gestational hypertension and preeclampsia is we get labs. We know that women
Mm.
with preeclampsia are going to have more protein in their urine. So you may have your doctor check your urine every time you come into your OB visit. You think we're just looking to see whether you have sugar or infection. We're also looking to see if there's protein because that can be an early marker for preeclampsia. And then the final type of hypertension is what we call superimposed preeclampsia. So that would be a woman who has chronic hypertension outside of pregnancy, but it gets acutely worse during pregnancy. And that can be pretty serious and highly concerning. And all of these different types of hypertension dictate how we manage the pregnancy, how often we're going to see you in the office, how we're going to do surveillance for baby, and ultimately when we're going to plan for delivery.
Thank you, Dr. Nelson. There is a question in the Q&A that is a follow-up. So I'll ask this: how early would protein appear in the urine?
So usually protein that's related to preeclampsia, since the diagnosis of preeclampsia can only occur 20 weeks and beyond, typically any point in time beyond 20 weeks. Definitely women who develop preeclampsia early on have a tougher road than, for instance, a person who develops preeclampsia at 39 or 40 weeks. If they're 39 or 40 weeks, we just deliver. It's just that area, the 24 to 25, where babies could survive, but they can have lots of problems that we concern ourselves with. You know, we're following the protein, we're following the blood pressures, trying to get women, you know, a little bit further along so we can keep mom healthy as well as having baby healthy as well.
Awesome. Thank you. Okay, the next question. What are the potential risks of hypertension for me and my baby, and how will it affect my delivery plan?
Very good question, Dr. Smith. So the risk factors that we worry about as obstetricians, so whenever I have a patient coming to my office, I like to look at what, with a chronic health problem, I want to know how is that chronic health problem going to be affected by pregnancy? How is their
Mhm.
pregnancy going to be different because of that diagnosis? And how is it going to affect the baby? So if we kind of look at those three silos, well, we know that in terms of chronic hypertension, we have women who come into pregnancy with that diagnosis. We know that they have an increased risk of developing preeclampsia, an increased risk of
Mhm.
having worsening hypertension, and an increased risk of end organ damage. And when we say that, we think about kidney damage, eye damage, liver damage. These are things that we worry about when we have uncontrolled hypertension. So how is the pregnancy managed? A little bit different for those women. We're going to see you more often, especially in the second half of pregnancy, where all of these things can further complicate how well mom and baby are going to do. We know that because of hypertension, that can make it necessary to deliver a little bit earlier, and sometimes a lot bit earlier. So we have higher rates of preterm delivery, higher rates
Mhm.
of small babies. And we monitor more often with ultrasound because we're tracking. We know, like I said before, that preeclampsia has something to do with that placenta. And hypertension has something to do with the impact of that placenta. So that placenta is what gives babies everything they need. So sometimes if that placenta is not working quite as well as it should be, babies don't grow as well. So that's the big thing that we worry about. And then finally, the thing we never like to think about, and sometimes if we have uncontrolled hypertension that is excessively high, we can have a condition called placenta abruption, where the placenta can prematurely separate from the uterine wall, and that can be catastrophic. So that's why we see you more often in the office. That's why we educate our patients on how to take their blood pressures and how to look for those red flags to know to reach out to their providers.
Okay, well, now I have a follow-up question. So most women will start off with their regular OB-GYN. As far as hypertension is concerned, when do you, as the MFM, maternal fetal medicine doctor, have to get involved? Is it gestational hypertension or not until concerns for preeclampsia? When do they also have to include you as a higher risk pregnancy?
I think we should always be involved. So
Mhm.
what typically happens at Northwestern is if we have a woman who comes into pregnancy with a chronic health condition such as hypertension, they will send her to my office preferably before she gets pregnant so that we can make
Ah,
sure that she's as
Okay.
healthy as she can be, because we know that that's one of the leading predictors in how that pregnancy is going to progress, uh, how healthy you are when you get pregnant. And I guess it makes sense.
Mhm.
So women who have just uncomplicated hypertension, oftentimes they'll come to our office, they have the consultation, we map out a plan, and they go back to their doctors. Those patients who have complicated hypertension, they're needing multiple drugs in order to control their blood pressures. Those patients are better served in our office. One reason why is we have more time.
Mhm.
Sometimes some of the general OB doctors, they have 15 minutes to deal with a patient visit.
Mhm.
I have 30 minutes to an hour. And so that gives me a little bit more time to kind of tease out things, and
Mhm.
a little bit more time for those hand on the door questions, as I'm walking out the room and the patient says, "Oh, by the way,
Wait, what about this? I have one more question. Yes, we love it. We love it.
by the way, I had a
That's
stroke last night." Yeah, yeah, I'm kidding. And so I have more time, and hopefully my patients don't feel as rushed.
yeah.
And
Okay. No,
definitely
that's
with gestational hypertension and preeclampsia, those patients all come to us.
and just so everyone knows, at least at Northwestern and many of the academic centers where there is a medical school, probably whatever the large hospitals are, there are always the MFM doctors on call. So they're
Uh,
kind of there, they're behind the
24/7.
scenes, they're there. So whenever there is an emergency or something unexpected, they will come in the room in addition to your OB team that's already there. So they come flying in, as a superhero. So they're always there in many hospitals, not all. They're
But
there.
Northwestern, yes.
Okay, next question. What dietary changes can help control blood pressure during pregnancy?
That's the question all of my patients want to know. That, I have hypertension now. Do I stop eating all the salt? You should always have a lower salt diet. You should. I mean, I think a lot of us eat way too much salt. And that contributes to dehydration, and it could worsen symptoms of hypertension. But definitely just maintaining a normal, healthy diet during pregnancy. We know that babies love carbs. We blame the babies. Uh, but making sure that you're getting your proteins and your fruits and your veggies, and yes, some of your carbs, and just having a balanced diet. I want my patients to know that we do not look for perfection. Nobody's perfect. And I think that if you go into it understanding that, you won't feel as guilty when you have that cupcake for dinner. But just a normal balanced diet.
I will say, as I've gotten older and, become more aware, because I feel like nutrition was not
It
like we
was
all got a nutrition class in medical school, but it wasn't the best. And it wasn't until I got more serious about exercising and working out and, wanting to lose fat and gain muscle that I really started paying attention to the ingredients and how much sugar and how much salt. And now I'm trying to teach my kids that. Like, if we pick up a frozen dish, look how much salt is in there
yeah,
versus if we make it fresh. Even the other day, where was I? Oh, I was a chaperone at the Museum of Science and Industry last week. And my kid, I don't know where he got it from, some vending machine. He pulled out like a Cinnabon or something that was in a wrapper. So I had to say, do you know how long this was probably in that vending machine? Like I would rather, and there was a stand donuts there. And I was like, I'd rather buy you a stand. Like, at least this was freshly made today versus this thing was sitting in this vending machine for all. So I had to, like look at the package on here. Can you even read all these ingredients? Because it was like 50 things on there. So I was like, okay. So then I had to shell out $3 for the stands. But
or stands
I was
donuts,
just
yeah,
trying to say there are some things, okay, you could do, yes. So I am now also paying attention to salt and sugar
and
in particular
carbohydrates, yes,
and carbs.
yeah.
Okay. Next question. How does hypertension impact my baby's growth and development?
So the placenta is the organ that connects baby and mom. That placenta is an organ that has lots of blood vessels, and we know that hypertension impacts blood vessels. So those blood vessels are the way that we give baby everything that he or she needs. So if those blood vessels are not as healthy, then baby may or may not get everything that they need, and that can impact their growth. and it can impact their level of activity. It can impact their life, actually. So we know that we do all kinds of things, like we put moms on the belts that look at the heart rate, and we call those a non-stress test. But basically what we're doing is we're looking to see how well is that placenta giving this kiddo everything that they need. Because we want to know, is that organ, that is the placenta, is it healthy? And hypertension impacts the health of that placenta.
I am going to ask one question about do you recommend when someone does have high blood pressure in pregnancy, should they have a blood pressure cuff at home? Should they be checking that at home and sending that in to you? Or is it only when you're in the office?
All of my patients who have hypertension in pregnancy are sent home with a cuff. Not only are they sent home with the cuff, we teach them how to use it. And I like to tell my patients, take your blood pressure after you're sitting 5 minutes, feet on the floor, not when you're running after your kid and you're going to stop there for a second and just, no, that's not the time. You want to take it the correct way to make sure that the reading is accurate. And that the other thing that we do is we make them bring that cuff to their office so that we can make sure that our cuff agrees with their cuff.
Okay.
And we give them parameters. These are the red flags, and these are the times that you call us. And
Mhm,
this is when you should be worried. And you
mhm.
should not take your blood pressure 50 times a day.
Right. Just like you shouldn't get on that scale 50 times a
50
day.
times a
Yeah.
day. Yes, I agree.
Okay, we have a question in the chat. Um, Thank you for this. What can I look forward to with my second pregnancy in the future, being that I was diagnosed with severe preeclampsia with HELP syndrome and delivered at 32 weeks?
And how's your
Thank you.
baby doing? I want to ask that myself. So we know that things that happen one time have a higher rate of happening again. We know that in a pregnancy that has any type of hypertension, hypertensive disorder, the risk of recurrence in subsequent pregnancy can be anywhere from 25 to 45%. So there's an increased risk that in that subsequent pregnancy that you will develop preeclampsia again. There are things that we do to try to mitigate that risk. Your doctor hopefully will start you on a baby aspirin. There have been all kinds of studies looking at what can we do to prevent preeclampsia, because it's such a big problem that we deal with. And the only thing that has been shown to have a modest risk of reduction is baby aspirin. So that was going to be the bigger thing. They're going to see you more frequently in the subsequent pregnancies. The likelihood of getting HELP syndrome, which is very rare. We talk about HELP syndrome is on that continuum of preeclampsia, and it's hemolysis, elevated liver enzyme, and low platelets. It's evidence of that end organ damage that I talked about earlier. So the likelihood of that happening again is actually very small, definitely less than 5%. But having any type of hypertensive disorder in the next pregnancy is high as 45%.
Okay, I was just putting the acronym for HELP syndrome in the chat. Okay.
Yeah, we use a lot of acronyms in
I don't
OB.
know if that went to everybody. Okay, yeah.
We use a lot.
Me too. Awesome. Okay, let me just see. Okay, I don't know if that went to everybody, but I'll redo that one. Okay, next question. Um, can hypertension during pregnancy affect my postpartum health? And how should I prepare?
Wonderful. Such good questions. So definitely. We know that if a woman has hypertension during pregnancy, well, before they get pregnant and they become pregnant, their blood pressure can increase and become more severe. And oftentimes they can carry that into the postpartum period. Oftentimes we think about postpartum being those first few days, but you can have symptoms of postpartum sequelae up to 12 weeks out. So oftentimes women, sometimes we're not on meds before, we'll go home on medication for those 6 to 12 weeks post-delivery. Sometimes they may need different medications during the time after pregnancy. As far as preeclampsia, we know that if a woman develops preeclampsia, she has a higher rate of, probably 2 to 5 times higher rate of developing hypertension post-delivery and carrying that as a diagnosis outside of pregnancy.
Awesome. Thank you. This question is about the symptoms of hypertension,
Mhm.
where I know the most common symptom is probably zero, no symptoms at
No
all. There are
symptoms at
plenty of
all.
people that have no idea that they have high blood pressure because they're feeling fine. And it's not until they get their that blood pressure cuff reading,
Mhm.
which of course untreated is was when you can have damage to the arteries, and then that is, irreversible. But and I know pregnancy also has can have all these weird symptoms
There's
that
so many,
no
yeah.
two people are alike. So half the time you might just think, okay, this is something new. I don't know if this is pregnancy. This little thing is in here. What symptoms, though, looking back, maybe has a patient maybe not realized that these were signs or symptoms they should have called you for?
Mhm.
What are some things that we want to make sure that people do not brush off?
So the biggest thing I don't want people to brush off are headaches. So I know that in the first part of pregnancy, you have that peak of one of the pregnancy hormones, and everybody gets headaches sometimes in the first half of pregnancy. But by 20 weeks or so, those headaches just start to abate. And a lot of us who are caffeine drinkers before pregnancy, and then we get pregnant and we cut the caffeine, we're going to have headaches. But we never want to brush off headaches. I have patients who say, I don't want to take any medication. I want you to take some Tylenol if you have a headache. Because if you have a headache that Tylenol won't get rid of, I need to know about that. That's a red flag.
Mhm.
That's something you need to come reach out to your doctor. Don't wait till that next visit. Reach out to your doctor so that they can make sure that that's all that there is going on. Sometimes patients just feel, agitated and kind of just not right. And I know that's
Mhm.
not a medical term, but you feel just kind of antsy in your own skin.
Mm.
That's something else we want to know. That's not normal. And then all pregnant women have swollen feet. That's gravity. Gravity is not your friend. We have swollen feet. But when we have what we call non-dependent, non-gravity dependent edema, so the person who lives with you, if they notice that your face all of a sudden is much fuller than it was yesterday, that's a red flag. Every pregnant woman that I see at some point in their pregnancy, they're going to stop being able to wear their rings. But it should be a
Mhm.
gradual thing. It should not be my ring fits fine today and now I got to get the guy with the pliers to take it off. It should not be that acute. These are a sudden onset weight gain. Um,
Mhm.
that's one of the reasons we check your weight every time you come into the office. It's not to embarrass you, it's not to chastise you because of whatever you've been eating. We want to look at what that trend is in your blood pressure because we know that a big jump in blood and weight can mean that you're retaining more fluid and it could be a sign of preeclampsia or worsening hypertension.
Thank you. That was awesome. Here, let me just give you a little update on our preterm baby. Uh, our patient says, or our listener says, thank you for that. Baby is good. He's 8 months old now, and he spent 24 days in the NICU. He did not have any health problems. Scary experience for me, and I didn't have any symptoms except for swelling.
Yes.
Thank you so much for that update.
Thank you so much. Thank you.
Okay. Next question. How might high blood pressure affect my delivery plan, including the potential need to be induced or early induction or have a C-section or a cesarean section?
So in terms of how hypertension affects your delivery is the biggest thing is the timing of your delivery. So I know a lot of women have the birth in their birth plan that they want to go into labor naturally and when their
Mhm.
body tells them to do that. And I think that that's all well and good. But we know when you have hypertension, the safest plan for women who have even well-controlled hypertension is to deliver that baby between the 39th and 40 weeks. So usually a week prior to your due date, because we know that at that point, there's no further benefit in staying pregnant and there's only risk. There's risk of developing preeclampsia. There's risk of um, bad things happening. So at 39 weeks, we're done. But for women who have preeclampsia, we may deliver those babies as early as 32 weeks, as our earlier young lady said, as early as 32 weeks. We do everything we can to optimize how well baby's going to do, but if it's affecting the health of the mom, we plan for earlier delivery. And we do lots of fetal surveillance. We do non-stress tests. We do Dopplers. We do all kind of things to make sure that baby's better off inside than out. And whenever you cross over that threshold of not being better off inside of mommy than out, we call Dr. Smith and we say, hey, we got a delivery for you.
And I will say, of course, there's been so many wonderful innovations that have come across all fields of medicine, but
Yes.
definitely in the NICU. And so,
Steroids.
of course, 32 weeks is not the plan. But we have babies that deliver as early as 24 weeks, 23 weeks, even 22 weeks. And so a baby that is 32 weeks, they usually do well. But it's going to be a length of time in there. But yes, so definitely continue to have conversations so you are aware and can hopefully help be aware of kind of things that could come as potential risks for the future. Awesome. Thank you so much. So hopefully you all can read the chat. There is information on there about high blood pressure, some risk you can't control, getting older, family history, race. And then some things you can control, too much salt, not enough potassium. Someone was just asking me. I definitely had those, what are the Charlie horses? I had
Yes,
cramps. That was
the
like the
cramps.
one symptom. It would wake me up literally in the middle of the night. I was
Yes.
like crying, like, what is happening? So I was like eating bananas. Oh my gosh. Let's see, lack of movement, smoking, heavy drinking, stress, poor sleep, obesity,
Make
and
sure you're
certain
drinking
health
enough
condition.
hydration. Yeah.
Yep. And then also, thank you so much. There is also a little bit in here more in depth about HELP syndrome. So again, Dr. Nelson kind of mentioned what it stands for, but you may hear us say HELP, but that's exactly that is what it stands for, and that's what we are trying to prevent. And so checking
Amen.
all those labs is what we're looking for. So thank you so much for putting that in there. Okay, next question. Let's see. Okay. Um, for postpartum care, what steps should I take to manage my blood pressure after delivery? I know you mentioned some people may have to be on medications after delivery, but what steps should a person do after delivery?
So we know that the pregnancy hormones and the postpartum period takes time to resolve and for you to go back to your baseline. And oftentimes women will have a peak in how high their blood pressures are immediately during the postpartum period. And that can be
Mhm.
usually between days 3 and day 7. So definitely keeping an eye on your blood pressure. You have that blood pressure cuff, continue to use it. I know it's a lot more difficult when you have a baby at home, but using that cuff, making sure you're paying attention to headaches, because we as moms can often just kind of write off things. We say, oh, it's because I'm tired. Oh, I have this headache because I'm tired. Maybe not. Maybe not. Sometimes moms are too tired I'm taking care of my baby. I don't have time to take care of myself. Yes, you do. Yes, you do.
Mhm. You
Um,
have to,
you
yeah.
have to. Um,
Awesome. And there's one more. Thank you so much. There's another in the chat, just specifically talking about managing blood pressure after birth. So making sure you take your medicine as prescribed, watch for warning signs, headaches, and other symptoms, monitor your numbers, reduce salt and processed foods, move when you can, light activity, and then prioritize rest and stress management. Awesome.
Easier
And don't
said than
ignore
done.
symptoms. Yes, yes. And again, with it being February and Heart Health Month, we want to make sure that with stroke and heart attack being the number one cause for women, we want to make sure that we are aware that we know the symptoms and we can recognize it in ourselves and in someone else as well.
Because oftentimes it looks different in women. My best
Mhm.
friend, who is very healthy, she teaches Zumba, she teaches classes, and she actually had a heart attack very recently. And the symptoms didn't seem like a heart attack.
Wow.
And she's fine. Thank goodness she's fine, but it doesn't present the same way. And She was literally teaching a Zumba class and she had some symptoms and where she just didn't feel right. And she went
Wow.
to the emergency room and they found out, yeah, she had a small heart attack. So
Wow. Well, I'm glad she listened to her body.
she listened to her body.
You mentioned baby aspirin. What are the risks and benefits of aspirin to help control blood pressure and to prevent preeclampsia?
So baby aspirin doesn't control hypertension. It controls the what we think is going on is the architecture or how that placenta lays down its
Mm,
foundation
mhm,
is not as good in women who have vascular disease, who have hypertension. And what that
mm,
aspirin hopefully is doing is helping with the architecture of that placenta so that we're able to
mm.
give babies everything that they need from mom. And there've been so many studies. I was looking the other day, the first studies were back in 1978. So that were
Wow.
it's been out a long well known that it improves risk women who are at higher risk. And so more recently, we've had studies that have actually shown, yeah, women who have a higher risk of preeclampsia, they can have 30 to 40% decline in their recurrence rate of preeclampsia if they take that baby aspirin. Our question now, though, is we're trying to decide what is that perfect dose. Right now, we recommend that patients take the baby aspirin, the 81 milligram.
Mhm.
But there are a couple of studies out of Europe and actually through the maternal fetal medicine network that are looking at, well, what about if 81 milligrams works? What about 150? What about 300? And so we don't quite know yet, but we definitely know baby aspirin. We have a whole list of people who should be on baby aspirin, and I think that list grows every year.
Awesome. And there is more information in the chat. I love it. Heart attack symptoms in women don't always look like men. They can have, women may not have the classic chest clutching pain.
Mhm.
They can have more subtle signs. And then again, a little bit more info on low dose aspirin helps prevent blood clots, and can help lower the risk of heart attack, stroke, preeclampsia, and then specifically helping to improve the blood flow in the placenta. So I love this. And hopefully guests can have this information in the chat too as well. Okay, let's see. Another question. Are there support groups available for women managing high blood pressure during pregnancy? Like, is there a group or?
I'm sure there are. I don't know off the top of my head, but I think your support group is your doctor, is your partner, are your friends. I think one thing that we as women do not do well enough is we don't tell people about things.
Yeah, yeah.
And, I have my patients who may have a diagnosis and they feel so alone because they're the only person that ever
Mhm,
had this diagnosis and they go home and they say something and their mom may say, oh, I also had that, or their cousin
mhm,
also had, but we don't talk enough. We really need to talk and kind of get rid of a little bit of that secrecy because that's how
mhm.
people learn. And hopefully things that happen may serve as something that helps somebody else prevent bad things happening for them in their pregnancies.
That happens all the time in the NICU, and a parent, shares with friends or family that that their baby's in the NICU, then they hear all these stories like, oh, their son, their daughter was in the NICU, and it's like, same thing with miscarriages. If you mention it, then people feel comfortable saying that happened to me too, but it is not something that often comes up in everyday conversation.
And we
So
understand why, but it's still helpful. It's helpful to talk about things and it's helpful
yeah,
to educate other people so that they know what to look for.
yes. Let's see. Um, We talked about baby health. Yes. Okay. Let's see. Are there any pre-existing health conditions that could increase my risk of high blood pressure during pregnancy?
So increasing your risk of chronic hypertension in pregnancy, not necessarily. But we know that women who have things like diabetes or lupus,
Mm,
arthritis, rheumatologic, autoimmune diseases are going to have an increased risk of preeclampsia or gestational
mhm.
hypertension during pregnancy. That's one of the reasons why I love for these women to come to my office before they get pregnant. So I can check your hemoglobin A1C. I can check your blood pressure. And if you have longstanding hypertension, I can get an EKG. I can get an echo if I need to, so that we can make sure mom is as healthy as she can possibly be, because if mom is healthy, baby's going to be healthier. So yes, chronic health conditions. And as we
Yeah.
look at our patient population now, women are older. We go to college forever, like Dr. Smith.
Black women, though, most educated, so we
Yeah.
are.
We go to school a long time, and then
Yep.
we're having our kids in our 30s and 40s. And I have
Yep.
even had many patients in their 50s, and now they're having their
Yeah.
babies. But with
Yep.
that comes life. The older
Yep.
you are, the more likely you are to have a lot of these obesity, hypertension, diabetes, lupus, in your health history. And so all of these will increase your risk of morbidity, specifically preeclampsia during pregnancy.
Awesome. And I'm just checking the chat. I love this. This is I don't know if Marie is doing this or is there like an AI bot in here, but I love this. There is information on online support groups. So there's a preeclampsia foundation providing information for women, resources, stories, expert answers to support questions. There's also Postpartum Support International, which offers some virtual support groups. And then there's also another organization called the Motherhood Center. So that is awesome. Okay, I'm checking our chat to see
You know,
if there are any. Yeah, go ahead.
So, when we talked about how pregnancy can be changed because of
Mhm.
hypertension, one thing I didn't say is sometimes the place where you deliver becomes
Mm,
important with
okay.
hypertension. Because specifically, if you're going to have a delivery that's a little bit earlier, you may not be delivering at a hospital where you had expected to. You may need to have a provider like Dr. Smith who can take care of your premature baby. Um,
Yeah.
so that's the other reason why it's so important to get consistent early prenatal care, so that we can make those plans and introduce you to those doctors if, for instance, you're having to deliver somewhere a little bit different than you planned. Every hospital is not created equally. Every hospital doesn't have the same resources. Every hospital doesn't have maternal fetal medicine 24 hours a day.
Yep. We had some applicants for our pediatric residency come back today and do a second look. So we had a whole Q&A panel. And one of the things that came up, so our children's hospital has been right next door. We are literally connected by a bridge to the women's hospital, and it's been 15 years, I think, 14 years. But the first couple of years that I was here, the children's hospital was about 3 miles north.
And
And
three
so
miles to
even
Chicago is a lot.
3 miles in Chicago is a lot. I know everybody here is from different cities, small cities, large cities, but our hospital, the women's hospital was had just been built. It was totally remodeled. It was a brand new hospital.
Beautiful
So
building.
people were coming from everywhere to deliver. They actually called the Hotel Prentice. And so people were coming from everywhere, the suburbs to deliver. And if there was a baby that needed to be transferred, so we do have a NICU, in our women's hospital, and that's where most of our babies stay. But occasionally there's a baby who is either sick enough or
Need
needs some
surgery or
surgery where we would have to transfer to the children's hospital, which is right now right next door. But before it was 3 miles north. And so those babies would have to get in the ambulance and travel. And the mother had just delivered and wasn't able to go immediately. And that was something that may not come up if you're not thinking, this complication could happen. And now, of course, fast forward many years, most of the prenatal, if there's anything concerned with baby, most of those prenatal anomalies or congenital concerns we're able to pick up prenatally. So then we can have a plan of this is where we should deliver, this is when, these are all the doctors that need to be there. But that is something that may not come up. I also have a cousin who her husband's in the military, so they have moved around to multiple cities and they were in a very small town. And She delivered a baby with Down syndrome who also had, which that was known prenatally because that is something that is quite common and was picked up. But she also had other anomalies, and that her daughter had to be transferred to another hospital, which was, but at least she had some preparation that this is going to happen. But it was like the military hospital, so that is something that is important, especially depending on where you live and what resources are available, and how close is the next, that level 3 or level 4 hospital that you need to be at.
Absolutely. No one ever wants to separate mom and baby, but
Yeah,
so that's why we have to try to plan ahead.
awesome. Okay. Um, Okay, okay. So I love this. All right, these are just some more questions for the listeners, for those of you here to ask. Is there a maternal fetal medicine specialist available 24/7? What percentage of births at this hospital involve preeclampsia or hypertensive disorders? How does your team handle high-risk pregnancies? Do you have a level 3 or 4 NICU? Absolutely. Is this something you don't think about until you
Yeah,
need it? The other thing I will say, they have I forgot what they call it. It's like a birthing class. What do they call the birthing class for parents
yeah,
when they're pregnant? And I just find they talk about all the good things and the happy things, which is good.
which is
But
great.
the NICU is not mentioned, or if it is, it's like a one-liner. And so often I would find parents were not prepared to, and usually it was something minor, like maybe baby had a little too much fluid, maybe had some respiratory
Sugar.
distress. Yeah, but it was often a surprise. They were like, NICU, what? And I'm like, we don't mention those in those classes at all. Yeah,
Oh,
10% of babies have to go to the NICU, usually not for a long period of time, but yes, it is. It can be a scary place if you're not expecting it, but it is. The babies do very well overall, and it is
yeah,
a
you guys do magic. Definitely.
wonderful place to be. Yeah,
One
I would
question that
say.
you asked that I didn't
Yeah.
answer
Oh
in
yeah.
terms of cesarean delivery. So
Oh yes.
preeclampsia is not necessarily a reason to have a C-section. So I just want to put that out there. Oftentimes
Mhm.
patients think I gotta be delivered. And often you can have an induction and have a vaginal delivery, which at the end of the day is better for mom and baby in
Mhm.
most situations. It does not mean you have to have a C-section. So yeah.
Mhm. Okay. Okay. All right. We have someone who is also weighing in, and we appreciate it. Um, Often our high risk patients would deliver at level 2 hospitals, and mom, baby, or both need to be transferred to one of the designated perinatal centers. Yep, you should ask your OB where they have hospital privileges that may determine where
Absolutely.
you can give birth. Um, which hospitals do you have admitting privileges at for labor and delivery? If I develop complications, will you still be the one managing my care, or will another doctor take over? If I need a high risk specialist or MFM doctor, do you work with one at the hospital, or will I be transferred? And then
Yeah,
why
that's
this?
actually a really good question because
Yeah.
at Northwestern, we do what we call total OB. So I have patients in my practice that are my patients. I take care of them from the beginning to the end. I deliver their babies and maybe their next babies. But the majority of maternal fetal medicine doctors do what we call consultative services. So
Yeah.
they work from 9 to 5, and maybe they made some better decisions than I made in life. But they do consults and they never set foot inside of a hospital unless it's just to step in and do that consult. So a lot of smaller cities don't have total OB maternal fetal medicine doctors, and that's okay.
Mhm.
Often what I do is I make a plan, and the general OB doctors are able to follow those plans. And we kind of talk about back and forth, and I have general OB doctors that will pick up the phone I'm on vacation, I was in the Bahamas, and someone called me to ask a question about their baby. And I'm like, yeah, of course I'm going to answer the phone. And but just making sure that they have access to someone who can answer those questions when your pregnancy is a little bit different.
Mhm. And speaking of that, I think about just now as a physician myself, if I have questions, whether it's an OB question, whether it's a one of my neighbors is a dermatologist. I have one kid that has eczema. I have somebody that I can like text, or if it's someone I don't, I can add. And did you know someone somebody was asking about a nephrologist, and I
Yeah.
can like ask, I have a quick question or of this. And I was like, that is a privilege, and like
Mhm.
everybody should have that. Everybody should have like a doctor or a nurse or someone in the medical field that they can reach out to, that they trust, that they can ask questions to, or at least not feel like I have to wait until my next appointment, which is a month away or 6 months away. And so that is wonderful that you have that relationship with your patients, that they can text you instead of feeling like I can't ask, or asking someone who isn't a medical professional,
Or going on the
um,
internet.
or
Don't do
going on
that.
the internet. Yes,
Don't do that.
yes, yes, yes.
I like to tell my patients that do not allow blogs to dictate your care. I tell them
Yes.
I've had two healthy pregnancies in my life and I've never written a blog. People who have bad things happen to them write blogs and they
Mhm.
write about it on the internet. And so that's, yeah, it's tainted information. Not saying that it's all bad, but
Yeah.
it's not your story.
Yeah. Yeah.
Yeah,
The other thing I'll say is, if you are going online, be careful what sites you're on. It should definitely be a reputable site, not just any site. So even if I'm looking up something, it has to be a school, a university that
or
I
PubMed or yeah,
no, yes, research article. So just because it's on the internet does not mean it's true, fact checked, proven. So do be careful of where you get your information. And be careful of even friends and family that may be very well meaning. I can't tell you how many texts I got during COVID. And I was
oh,
like, this is not true. No. And I'm like, don't, no. So,
yeah, that family
so
pay during COVID got real
yes, I
heated.
was like,
Got real
no, no.
heated.
Okay, there is another question in the chat. Yes. Okay. Is there research that indicates that women who experience hypertension or preeclampsia during pregnancy should have thorough postpartum follow-up due to an increased risk for future cardiovascular disease? I think you maybe touched on this a little bit. And then
Absolutely.
do they also need a cardiologist?
Not necessarily a cardiologist. They need an internist, an internal medicine
Okay.
doctor who can take care of them, who can make sure, is this something that's just related to that pregnancy, or if this is something that was just kind of uncovered because they were pregnant. We know that the medicines that we use to treat hypertension are not the best hypertension meds that are available. Once you're not pregnant anymore, it opens up the door to all these wonderful drugs that can not only take care of your blood pressure, but they can help your
Mhm,
kidneys. Not only take care of your
mhm.
blood pressures, but they can help with anxiety. Not only take care of your blood pressures, but they can help, they work together, meds that work together that we don't like to use so much in pregnancy. So absolutely everyone should have an internist, a general
Mhm.
medicine doctor who can be there to answer those questions and make sure that your day-to-day, year-to-year health is taken care of.
One thing that you said earlier that definitely struck me. So we are very good about making sure our kids go to
Absolutely.
the doctor from birth through 18, vaccines, their well child checks. Most times you have to have it for school or daycare. So we don't play when it comes to our kids. They are going to be up to date. And then a lot of us after that, whether it's we're going off to college, we're healthy, we don't have the pediatrician anymore. We're not sick enough in college or, young 20s to have a doctor. And so that's when we kind of fall off, both men and women. And then for women, at
Absolutely.
least, that is usually a time where we are at least brought back into the medical system during pregnancy. That's a lot of times when all of your, not only people, a lot of people don't know what their blood type is until
Yeah.
pregnancy. If there's a risk for sickle cell, there's a lot of things that because you're pregnant, and that sort of brings you back in. That's definitely another way where we lose a lot of men too. But yes, that is important because even after the pregnancy, especially if baby is fine and now you're exhausted and doing all the parenting things, is to forget to follow up and make sure you're clued back into an internal medicine doctor. So that is very important. I still see both. So, I still say my OB, but really I guess it's my guy. But I like I have to have this doctor is for this, and I have an internal medicine doctor for that. So I keep all of mine.
Absolutely. Absolutely.
One other thing that you said that also struck me is you said wonderful medicines. And I know that, no one wants to take medications,
Never.
um, but right, no one wants to. But I will for sure say that, and I remember this myself as a medical student. I was very much like, I don't want to take any medication. I remember I didn't. Like if I got a cold or something, I would just stick it out. I thought it was like me being tough. And when I was a medical student, I had all these symptoms and I could not like keep up in class. And I was like, no, I got to take something. I can't sit in class for 8 hours. And so I took like whatever, cold congestion medication, and I felt better immediately. And I was like, what am I doing? Like, not, why am I suffering through this? So that was one. So again, not taking medications just to be taking them, but when I have symptoms, taking them. Even when my kids have a cold,
Why
I'm
they're
like,
here. That's why.
exactly. I'm like, are you coughing? Are you sneezing? Do you have congestion? Because we need to take the medicine that you need, not just any medication.
Yes.
But I do want to say there's a lot of sometimes out there that doctors and pharma, absolutely not, or at least not in this world. Definitely there was no kickback in pediatrics for sure. But just to say that, for high blood pressure, especially, again, because it is that silent disease, one of the silent diseases, um, making sure that if you need to be on medication to control your blood pressure is to prevent damage to your arteries and all these other things that can happen, including heart attack, stroke. Because again, once that damage is there, it's irreversible. And I will ask this, Dr. Nelson, are there times when women or people can come off of blood pressure medications?
Absolutely. Before I do that, I want to talk about one thing that happens so often in my practice. Patients don't come for care until they get pregnant. And
Mhm.
they may be on medicine for anxiety or they may be on medicine for diabetes, but then they get pregnant and then they don't want to take any medicines and they stop all their medication.
Yep.
Don't do that.
Yep.
Have your doctor work with you to take you off the medicines that are not safe, to replace them
Yep.
with safer alternatives. And sometimes the medicines that you're on are actually okay to take when you're pregnant. There are some medicines that we can take. In terms of one thing about hypertension that's kind of interesting, and I guess maybe is doctor interesting, is what happens is you have this circulating hormones, one specifically called progesterone, that causes your blood vessels to relax.
Mhm.
So in the second trimester, you have the first trimester up to 14 weeks, second from 14 to 28, 28 to 40. During that mid trimester, you have maximum dilation of those blood vessels, which allows your blood pressure to come down. That's for all pregnant ladies. They have the best blood pressures of their life in the second trimester. We know that women who have chronic hypertension, it's more exaggerated. So
Mm.
oftentimes women who are on medicine outside of pregnancy during the second trimester, they don't need any meds. I remember
Mm.
when I was pregnant with both of my boys, second trimester, no meds.
Okay.
So yes, absolutely that. And that's one of the other reasons we want patients coming in regularly for those visits, because if your blood pressures are dropping low and you're feeling like garbage, we want to figure out why. And sometimes it's because you don't need the medicine for a minute. And then of course, third trimester, reality sets in again and you need your meds again. But we want to have that doctor there to help you kind of walk
Mhm.
that trajectory of the pregnancy when you need meds, when you need a little bit more, when you don't need as much, and helping you to have a healthy pregnancy.
Dr. Nelson, can you believe we are at the end
Oh
of
my
our
goodness.
time? I knew that was going to go fast. Well, we are right at 7:30 Central Time, 8:30 Eastern Time. I know you all are joining us from everywhere. Thank you. Okay, I learned a few things in there, and I'm going to be passing it on to my crew in the NICU and to my friends and family that asked. So thank you so much. So again, all in our little separate fields, but we learn a lot from each other, and I hopefully you all learned information here. There's a ton of things in the chats and other websites and things that you can, go to, including Birthing the Magic. There is another webinar that's coming up next week, I believe on February 22nd. I hope that you all join us as well for that one. That one is going to be more focused on preeclampsia. So we sprinkled a little bit of preeclampsia knowledge in here, but kind of focused on blood pressure. And then for those who are interested in continuing education for nursing, there is a QR code in the chat that you can get for that as well. Dr. Nelson, thank you so much. I don't know if you're working this weekend. I'm on call Saturday night, so I don't know if I'll see you.
No, no, I'm
Not
I'm
this
I'm
weekend.
chasing children this weekend, so yeah.
Okay. Awesome. Well, thank you all. Have a wonderful night, and I hope we can do this again soon. And thank you all for
Thank
the
you for
questions
having me,
as
Connie.
well.
Thank you.
Yes. Awesome. All right. Good night, everyone.
Good night.